now, doctors.
Friends, warm welcome to all of you. It is yet another collaborative program between the IAGES and the ALRSGBI. We are happy to share IAGES is following the threads of ALRSGBI. From very soon, it will officially become IAGERS. So the president has initiated the process for that, and once the EC approves, and we have certain technical processes, so IAGES is also becoming IAGERS. With that small information, I warmly welcome all of you for today's program. This is going to be the most commonly faced trouble by all the surgeons across the globe, the bile stones and the nuances one has to be uh, aware of. So without much ado, I invite our president, Dr. K. Govindraj, to give a welcome from our side, and then we move on to the LRSGA president.
Yeah, thank you, Dr. Kanagavel. It's a nice day here in Edinburgh. For a difference, I am addressing the IAGES ALRSGBI from Edinburgh, and it's wonderful to have this kind of webinar, and that too the topic, which is, as Kanagavel said, which is a very nice topic. When you are in difficulty, you would really feel that somebody talked about it, you would feel the difference. And we have got all luminaries in this topic talking today. And with this, I'll just go ahead with the next person who is going to be there. And thanks for ALRSGBI President Dr. Selvashekhar for making up this kind of an joint webinar. And the first webinar happened a month ago, and it was a wonderful one, well received. I hope this one also be well received. Thank you.
Thanks very much, Govindaraj. It's always a pleasure to work with IAGES. We've had this collaborative webinar series for a few years now. It has worked very well, although we are evolving with based on the feedback we receive from the delegates. So delegate feedback is very important. Although the pathologies are the same, how it is managed in the different parts of the world is quite fascinating based on the healthcare resources and also based on the needs of the population and various other factors which come into. So it has been a very good learning experience for everyone. So thank you, everyone. Thanks to Dana, Shafaq, and Graham from our ALRSGBI who lead the webinar series from the ALRSGBI. And the IAGES team, it works very well collaboratively. So finally, just a sort of a short spiel about the ASM, the annual meeting in Manchester for the association is on the 7th and 8th of December, and IAGES are planning on sessions in London and in Manchester. So I look forward to welcoming a lot of IAGES members to this year's annual meeting. So without further ado, we will make a start. I think we are having problems with our moderators today. I can't see Graham. So what I will do is I will introduce Professor Lash, who is a consultant colleague of ours, who is an interventional radiologist. He did undergraduate training in Germany, and he has passed MRCP in 1995. He's a very experienced radiologist. Some people may about the practice of the Christie, which is more of a tertiary practice, and he comes up with innovative ways of addressing problems using stents and drainages. So I thought it would be fantastic for us to hear from Dr. Lash about about the management of the GI side of things from the interventional radiology perspective. Over to Dr. Lash. Thank you.
Thank you very much for the kind introduction. And I've got a terrible echo. Not quite sure where that's from. So that's better. Thank you. Good afternoon to the British team. Good evening to the Indian team. I'd like to thank you for the invitation and for the late substitution onto the team and allowing me the kickoff from a very sunny Manchester, where some of us are keenly awaiting the performance of the Ivory Coast team tonight. I'm not sure what you can see. I see that it seems that the green frame is still around Sekar's screen. I will now switch to screen share, and I hope that you can all see that now.
Yeah, you can see it.
Again, there is a massive echo, so I will just try and ignore myself. Oh, I see the sharing has stopped. I'm not sure what that means. I don't know. I see a beautiful picture of a very strong and powerful man on the screen. Question to tech, is my sharing visible?
The sharing is done, doctor. We are seeing your screen.
Okay, fine. I'll just crack on then. I wasn't entirely sure. Well, I wasn't aware that this was a biliary stone session. I do have some experience, although that goes to previous life. We are a super regional cancer center, so we don't really deal with stone disease and not so much with benign disease either. I've been asked to talk about the challenges we face in GI intervention from a radiology point of view, and I thought I'll focus on a couple of topics. Before I start, I have no declarations of interest I need to make regarding this talk. Nobody's going to pay me a penny, but as head of a medical foundation, we do have very close collaborations with industry and have many partners within that, none of them relevant to this talk in particular. The challenge I was going to concentrate on is GI stenting. And I don't think we will have time, but I also prepared gastrostomy in special circumstances, which is really in small and large bowel obstruction. But I have a feeling we'll be running out of time. In terms of stents, the challenge we face is really one big problem. The patients now last longer than their stents. We have a beautiful baseline, a multidisciplinary between the Association of Upper GI Surgeons, the British Society of Gastroenterology, and the two relevant radiology societies. And from that initial report in 2004, at that time, if you look at the yellow bars, the survival drops off pretty dramatically over the first 6 months after stent insertion. This is esophageal stent insertion. In a contradictory development, if you live longer, you will have more problems with your stent. Not entirely counterintuitive, but to put this in a more visual context, in 2003, the average survival was 3 months. In 2018, which admittedly is now 8 years ago, the survival was coming up to 18 months. And we've got further from that. Great for the patient, not great for the devices. In 2021, we had two first milestones. That we had our first patient living for 3 years who needed 9 separate stent procedures, 5 stents migrated, 1 perforated the small bowel. We also had our first patient live up to 5 years. He only had 5 stents. So that in itself, for a patient who's already malnourished with the main symptom of dysphagia, which is debilitating and socially isolating, and I can't overestimate that because everything we do hinges around food and drink. We go for a drink to the pub, we meet for dinner, Christmas dinner, business lunch. It all hinges around eating and drinking. If you can't swallow, you're not part of the crowd. Stents are made from a clever alloy. It was developed by the US Navy and first applied in the US in the F-14 Tomcat, and therefore I could claim it's Top Gun approved. But nitinol, which is the alloy, is everywhere in daily life. Anything that is kind of elastic metal, like pop-up tents and braces for the teeth, are usually nitinol. And it has 2 fantastic qualities. It's 30 times more elastic than steel, and it has shape memory, which for medical devices is imprinted and annealed for body temperature. So the device remembers its shape that it's supposed to be in best when it's warm. Now, patient survival going up has a huge number of problems. It may be that the treatment works even in a palliative context and the tumor shrinks and the stent falls out of position. It may be that tumor slowly overgrows the device. And all of these require an increasing number of revision procedures. For the purpose of this talk, I'm going to focus on the bottom 2, looking at the stent for the first stent you choose, and also what's going to happen to it in the long term, because this is as yet poorly recognized across radiology, across surgery, and across gastroenterology. From a recent survey, we know that 50% of patients need at least a second stent. 30% need 3 stents or more. These are all procedures that the patient is frightened of, and in the meantime, they develop dysphagia and they are already malnourished by definition. So what we're looking at is a small tip of a very big iceberg that is coming our way. It has challenges for our practice. I am not considered a clinician by our job planning people, so I don't have a clinic. I can't provide follow-up. I'm even struggling to give decent consent. So what I've organized in our department, I've trained 3 radiographers who perform 2 monthly contrast swallows on these patients to keep an eye on them, keep tabs on them, and catch complications as soon as they develop. I'm also very lucky that myself and a colleague of mine are signed off in upper GI endoscopy. I also was signed off in ELCP, but this was in previous life. So we are lucky enough that in our department, we bring the expertise into one room from both specialties, which is a huge bonus for the patient. What it means for procedure planning, it's not so much, are we going to score a 5th goal against Croatia? It's what are we going to do when we meet the Germans for a penalty shootout? And translating that to procedures, it's not what am I going to do today, but when the patient comes back, what options have I left, depending on what I did initially? We have a big program in the UK, which started in surgery, in orthopedic surgery, about getting it right first time. And it is crucial to choose the right device correctly so you have the best possible options in the future. That's not limited to esophagus, that's duodenal, that's colonic stenting, and biliary, and particular biliary, because it's much more complicated around the hilum. To start with, it's really crucial to understand what we're dealing with. This is an old-fashioned standard stent construction. We call it braided. The manufacturers call it different things. It's the old wall stent design with crossing wires. It's flexible, but it always wants to be straight. If you cover these in silicone and glue the wires together, this will no longer bend. It may kink, but it will not want to be straight. It will want to be straight. So if you need to go around a corner, this is not going to work well. The other main construction is where the wires are hooked round each other. I call them knitted, and that's been widely taken up. But there's also hooking wire and D-wire, depending which manufacturer you use from. And they don't need to be straight. They tend to be covered with a loose membrane, in this case Gore-Tex, but it can be silicone. But this is not attached to the wires, so the movability is maintained, the conformability is maintained. They can absorb peristalsis, therefore they migrate less, but they have no problem going around the corner even when they are covered. This applies to stents across the GI tract and including biliary. We use 2 extremes from the spectrum that is available. We use a very soft conformable stent. It doesn't migrate very much across the GOJ because it can absorb peristalsis and work with it rather than behave like a foreign body, but it has a relatively low expansion force of about 39 Newton. On the other end is a really strong stent that is probably the best in terms of staying in place across the GOJ. It has these flaps that anchor it, but it has a very high expansion force, nearly 4 times more than the other one, but it won't bend. So if it's a very tortuous GOJ, this is not a great choice. For everything else, it's a really good choice. Migration is a problem we haven't cracked yet. We know from the 2nd iteration of the stent registry that the average migration rate across all stents across the UK is 1 in 6. That is shocking. You wouldn't buy a television or a radio or a dishwasher where you knew a 1 in 6 would fail. But if you drill down on it, this is as high as 40%. So some of them are really not fit for purpose. There are several factors that play into that, the anatomy and where there's been previous treatment, but the main factor is the stent itself. Sometimes they don't slip all the way. As you can see here at the top, this is just moved into the tumor. It's bending into the stomach. But looking at this closely, the lower end is splayed up. It's fatter than the top end. And that's because it's bumping up against the greater curve of the stomach. Well, it's easy to fix the top end as we have here seen on the CT, but the bottom end, gastric mucosa, is invaginating into the lower end, and this stent will never work. Now, the key of this is getting it out rather than just putting more metal in. When the stent falls completely into the stomach, that's in the past not really regarded as a problem, and we tend to leave them there. Most stents stay in the stomach. The ones that leave the stomach tend to end up in the toilet, but the more patients have a problem with this, the more catastrophic complications may happen. So being able to get them out is a key feature. Now, removing a stent and removable is debatable. This is an Ultraflex second generation, now 5 generations out of date, in my opinion. You can rip them out, but you might run the risk of a partial esophagectomy, but it's all possible within reason. Proper stent removal can be done from the top by capturing a purse string, as you see on the left, and simply pulling it out. If the stent's intact, that's really easy. But you can also, if they are knitted, grab them from the bottom and invert them into itself, a bit like a sock taking off that goes inside each other. It's less traumatic, certainly causes less bleeding. Here's an example. The endoscope's in place. We're capturing the lower end of the stent, and the blue bar is the top end of it, just as a landmark. It is then captured, and as we remove the endoscope, the stent just folds into itself, out it comes, and there it is. That is usually a very easy thing to do, assuming the stent is intact. We don't really want to leave migrated stents in place for too long, because you might end up with positions like this. It's quite funny, except if it's your own stent, and this is starting to impact at the GOJ. At the ileocecal junction. CT of a different patient, similar situation. You can already see the distal ileum is dilated and with fecalization of the content. There's mucosa invaginating, and around the stent there are changes developing in the fat, which tell us that this bowel is getting sick and it's about to perforate. And I really don't like it to meet Seika in the morning to find that he was up all night trying to fix something that went badly wrong because we didn't remove the stent in time. So when the question is to leave or not to leave when we see a migrated stent in the stomach, we have completely changed our tune. We'll do everything we can to get it out, because the patient is likely to live not another month or two, but easily another year or two. Occasionally we get it completely wrong. By we, I not so much mean we, but if the flexibility or rigidity is not properly understood, a rigid stent here placed across the GOJ sits there bolt straight. It has shape memory, it wants to be straight, and while it looks okay on the native X-ray, by the time you put some contrast down, that angle and the stent lying across the lumen prevents the patient eating properly. Fluid may go through, but food won't. An example from the colon, this wall flex, it should have gone around that angle. It doesn't want to bend. It wants to be straight. It tries to straighten out, and the distal end is embedded in the bowel wall. The feces would have to go through the side of the stent. And although it was placed in the correct position, it never worked. The patient had no relief and remained in complete bowel obstruction despite being stented. An example from ERCP, just a glancing blow at the biliary theme. A biliary stent correctly placed via ERCP, the arrow demonstrates it's flaring out into the duodenum, and of course, when it's being deployed, we like to see the lower end just protruding beyond the papilla. Great in place, everybody happy, except the low function tests do not improve. The patient has a CT scan 3 days later. There's the pancreatic tumor where it should be. Down there's the duodenum, and the stent has just pushed itself up. That is now an almost catastrophic position to try and resolve, in particular if it was a covered stent, because it might block the hilum. Equally, if it's a bare stent, it may become embedded. We have created an emergency. If a knitted stent had been chosen, that will go around the corner like this one, almost 100 degrees, patent lumen, no straightening forces, no problem. So if in doubt, something that can behave like this is clearly preferable to something that needs to be straight. Our particular problem is patients who've had a partially covered stent placed, which on the surface of it is an appealing concept. The idea is that the metal ends, the bare metal ends, will fix the stent so it won't slip out of position. And that may be an idea when the patient has a very poor prognosis. The only problem is that takes a little while, and these stents often migrate before they have fixed, and then they embed themselves in a position where they're not working. The main culprit here is the old Ultraflex on this absolutely amazing delivery system with 10 meters of yarn, but the ends are bare. Excuse me. And here on the CT, beautifully shown how reactive overgranulation has fixed this stent. Except This was a patient with a benign stricture. This was a post-radiation stricture, which in a DGH, where there was no expertise, was treated under the instructions from the surgical center to have the radiation stricture stented. The operator thought it was a covered stent because that's what it says on the box, except Ultraflex is never fully covered. The patient had a fatal aspiration and died after having been cured from her cancer. When they slip halfway, that isn't necessarily a great plan because they will fix themselves. And here we have the example of the contrast swallow. The stricture isn't covered. It slipped down till it abutted the stomach. And we now see tumor ingrowth through the top of the stent where the lumen is narrowed, and that limited the patient's swallowing. And now the stent is fixed. It's usually impossible to remove, even with stent removal procedures or with argon plasma beam coagulation. This is a poor outcome. The top end may be revised quite easily, sticking another stent in, but we can see that it's still abutting the rotator cuff of the stomach, and this patient, despite 2 stent procedures, was condemned to nasogastric feeding until they died. A terrible outcome, which would have been better if the first stent had been chosen more considerately. We have a sizable research program looking into stent failures because we have the questionable benefit that the Christie, as the cancer center, gets the follow-up of everybody else. The patients have their stent in their surrounding DGHs, yet they come to us for chemotherapy. We inherit other people's problems. So we see a lot of these where the stent is broken, it's been eaten away by the gastric acid. You put an endoscope down, you see a wreck of a stent, and sometimes only half of it is left or less. We have metallurgists in Prague and the Advanced Materials Department in Manchester, both running PhD programs on this. We've had some fascinating results. What it's also helped us to do is get the right people around one table. The clinicians who deal with it, on the left is Derek Edwards, our previous devices specialist, who unfortunately no longer works at the Christie, scientists who understand metals and corrosion, and manufacturers. And that's how the Koreans got so far ahead of the curve. They had the 3 key components in one room. A very quick look at some of the results. So we found that explanted stents have easily lost 50% of their total metal. There are certain patterns that we can see on the scanning electron microscope, that crystal formation happens on the surface of the wires. Pit erosion happens underneath, a bit like caries and tooth decay. Pepsin staining is rife, and the wires flatten and thin out when they should be round. It leads to what's called nitinol embrittlement. The superelastic wire is no longer elastic, it starts to break. There are a number of factors that come into this that we're still trying to explore, but the clinical outcome is that these stents simply fail. They lose their 2 key components, and it means that we have to anticipate that these patients have a device that will break. We need to keep an eye on them so we don't end up with a stent where its life is hanging by a thread. The quality of the original nitinol is important. Also important is how it's being handled, but the key function really is gastric acid. We've got some amazing publications in the metallurgy literature which demonstrate that there is a real problem with nitinol in an acidic environment. Just to see how bad that becomes, here I'm hoping to take a stent out. We put the scope down and already this is not looking good. There is a stricture, so it's probably slipped a little bit into the tumor. The top of the stent is hard to identify. There's a bit of lumen on the outside, yet we can just about see the capture string, which I'm trying to grab there, but there's already a fractured wire smiling at us. We can see ingrowth through the membrane, which has perished. And I thought I'll give it a tug, but it's already a poor sign when you can see lots of broken wires there. Gave it a little bit of a pull and you think, yeah, it's coming, it's coming, it's coming. And you think you're going to get this out. And then all of a sudden it goes ping. It's never good when it goes ping in a patient. Had another look down, and this is what I call a brown trouser moment, where you've seen the stent is no longer intact. There is no way you can remove this, and all you can try is drill another one through it. Just going to finish off quickly with the new thing, the TTS stents. In the past, endoscopists have had to place esophageal stents alongside the scope, but they've now been accommodated through the scope systems. But there's a catch. If you compare an 18 French versus a 10 French system, and I assume you all know that a French is 1/3 of a millimeter, this is almost halfway down. The only way you're going to get a stent into that system if you make the stent weaker, if you reduce its expansion force. We tend to call it radial force, which is not quite the correct phrase, but when we looked into it, there's no standard, neither in America nor in Europe. We asked the stent manufacturers, how do you measure them? And they said, well, half of them didn't. And the other 4 had 3 different ways of testing expansion force with 3 different units. We took all available colonic stents to Arizona, put them through a test system that looks like this. I won't go into too much detail. We had 2 esophageal stents for reference. We tested 25 colonic stents, which included the biodegradable. And the outcome was amazing. So the median was between 20 and 30 Newton. But if you look at the range, the one thing a stent needs to do is to expand a stricture. That's the only thing it's there for. And you would think that the forces would be somewhere in the same ballpark. They're varied by factor 24. That is insane. This can't be right. And it shows how hopeless the current devices are, that nobody really understands what they need to do. This illustrates the range of the expansion forces, the knitted in green and the braided in blue. If you look at the right, these are our 2 esophageal stents I showed you before, and they are way stronger than the available colonic stents, most of them, which means if you put them in a smaller tube, the stent has to be weaker, otherwise you can't get it in. So the drawback of using through the scope stents is they are much weaker than its colleague that goes over the wire. And the temptation is to do it without X-ray control, which of course I, as a radiologist, can only condemn. But there is a point to this. You wouldn't place a biliary stent through ERCP without X-ray control because you wouldn't know where the wire's gone. So if you're choosing a stent, bear that in mind. First of all, if they're really weak and you have a massive bulky tumor like this, it's not going to work. Here's one. This was placed in January, and this stent never had a chance against that bulky tumor. In September, the patient comes for a revision, which means the patient has struggled for 9 months after stent insertion with high-grade dysphagia. The stent had perished, the wire went outside, and the secondary stent was placed alongside, which meant that the patient that to that point had been dysphagic was now aphagic. All we could do, because these were uncovered or partially covered, we couldn't remove them. We rammed one of our strong ones inside, which gave a decent lumen, and luckily worked. But that was luck. That was just not entirely by design. So in a word, if at all possible, I think a removable stent ought to be used because it will allow us options in the future, and the patient is likely to come back. So in summary, I think more than ever, this should be a multidisciplinary approach. I think the stent failure can be readily demonstrated by radiology. For stent removal, endoscopy is key. And for those who put them in, don't think about today, think about next time. I think we're out of time, so I will skip the gastrostomy and I go straight to a bit of art from the electron microscope on corroded wires. Thank you very much for your attention.
Thanks, Gula. That was fantastic. Well done with the the practice we have and also your research side of things. We'll wait and then see. I can't see any questions in the group. Are you all right to wait for some time, Hula?
Sure.
Yeah, okay, that's
Okay,
great. Thank you.
Yeah. Professor Hula, that was a wonderful presentation.
Thank you.
And we been doing a lot of this esophageal stents for almost since 95. One observation, what exactly we looked is the one you were telling. That's the patients outlive the stents. It's what I've been telling everybody. They've been outliving the stents. Yeah. Number one. And I just want your experience on, you already put up a disclaimer, but still, I just want your experience or in your experience of so many years. These Korean stents nowadays, I feel they are so flexible, and they are comparatively to the Ultraflex, and it's very easy to place. And definitely we don't use the TTS, still we do with the fluoroscopy for the esophageal. And in our experience, we always use the upper and the lower uncovered, because that definitely reduces the migration. One more thing is, in our experience, we have given up that stents with the dangling part in the bottom, which they say it reduces the reflex, but we didn't find that much of reduction in the reflex. I just want your experience on the Korean stent, 2 on the uncovered upper and the lower part, and 3 on this the stents which are used for called the anti-reflex stents. And fourth one is, we have used a lot of these beta stents particularly for this C-shaped or the D-shaped ones. And what is your experience on that?
Okay, so I'm trying to remember these in order. So Korean stents, most of these are what we call knitted, so they're extremely conformable, will bend. Not all of them. If you go to Taewong, they've got some really stiff ones, and they have the double, which is supposed to migrate less, but I've not seen that. We have, as I've shown, we have 2 extremely fundamentally different stent constructions, which we choose for different circumstances. In our practice, 70–80% are adenocarcinomas of the GOJ. Therefore, the migration rate is high, and we have found, and we still need to publish that, but the stent I showed you with the flaps, which is the stent from Ella in the Czech Republic, is the one that slips the least. It is also, for reasons we don't fully understand yet, the most corrosion resistant. It seems to be bomb-proof, but it won't bend. So if there's a very tortuous GOJ, we will go to a knitted stent, and there's little difference between Hanaro, IAGES, or the Taewong stents. So, but the catch is that most of the knitted stents have a thinner wire gauge, so there's less bulk in the wire, and it's exposed because it's covered on the outside with EPTFE. So they corrode really quickly. So they need closer follow-up. In terms of the partially covered ones, I find that at least half of them I need to revise. And the easiest thing, if we can just take the old stent out and put a new one in, we've got a level playing field. It's clean. There's nothing there. Putting more metal in more metal loses more function. More peristalsis goes. And there's no guarantee that they don't have a problem. If you have a knitted stent, they often fold in because they haven't got enough space. If you have a braided stent, you have a soap bar effect where they ping upwards and displace proximally. So if at all possible, we will take the old stent out, and that's our main reason to only work with fully covered. In terms of the anti-reflux valve, I think that's the wrong name. I think it should be an anti-aspiration valve. And if you look at the stents on CT, or if I didn't bring my beer bottle talk, where I've just got some very crude experiments showing that the valves reduce regurgitation by about 90%. So the speed with which the stomach empties in the chest when the patient lies down is massively reduced. I have unfortunately seen 2 patients die from aspiration pneumonia after open stent insertion, and our very first study as a fellow was on these, and they were totally convincing, and we asked every patient specifically. So across the GOJ, we will only use a stent with a valve, not to control the pH in the esophagus, but to stop the patient aspirating. And there was another question, which I've forgotten.
About the beta stents.
Oh, the beta is enormous. I mean, it's kind of designed really for sleeve leaks, which we have no experience with because we don't bariatric surgery. With the 2 stents we have, I think we've probably covered the best available stents in those 2 permutations.
Thank you, Professor Hans.
Thank you. Thanks, Hula. Hula is very passionate about stents, and he likes to put multiple, one on top of the other, take over the whole of the GI tract if possible. Thanks, Hula. Thank you very much. And he's very much interested in teaching and training as well. So when you're here next time, Govindaraj, during the conference, if you want to have a catch up with him in December, please do. He has got a wealth of experience, and he's got a huge research portfolio as well. Thanks, Hula. Thanks again. So
Thank
who
you
is
very
the
much
next?
For the invitation.
It is, I think, IAGES team. So
I will do that.
You need introduction, or I can introduce you, or Kanagavel can introduce you.
I'm here to introduce Dr. Govindaraj.
Okay,
So let
great.
me do the honor. So Professor Govindaraj is
is a very, very renowned gastrointestinal surgeon and a therapeutic endoscopist, and is a great academician. And he is the current president of IAGES, and is also chairman of Vishwanath Specialty Hospitals at Trichy. And he's also a governing council member of Association of Surgeons of India, which is a great surgical body, hailing from India. So Dr. Govindraj has immense experience in endoscopy and minimal access surgery. So with that introduction, I'll ask Dr. Govindraj to kindly, give his presentation. Thank you.
Thank you, Bharat, and thanks for that short and sweet introduction. And as you said, today I'll be talking on not the regular ERCP. I'll be talking on ERCP, which is going to be really difficult for the beginners. And that's going to happen in surgically altered anatomy. Okay. And next slide, please. To introduce that, you have nowadays, after the advent of this bariatric surgery, the choledocholithiasis is very highly prevalent in patients' previous gastric and bariatric surgeries. And altered gastrointestinal configurations makes the standard ERCP very, very difficult, and high risk of severe complications like the acute cholangitis, biliary pancreatitis, if it is left untreated. Next slide, please. A summary of surgical alterations are, these are the common things we see nowadays. Bile-Rhoth 1, Bile-Rhoth 2, and Roux-en-Y gastric bypass, or you call it the RYGB, and Roux-en-Y hepatico-jejunostomy, or RYHJ, and post-Whipple's procedure, or a switch, or a biliopancreatic diversion. It's called a duodenal switch. The main anatomical barriers here are long enteral limbs, which makes it very difficult for the access, and excluded gastric remnants, particularly in ROEGB, and angulated jejunal anastomosis post-Whipple sometimes, and retrograde access path in all these ROEGBs or post-Whipples. It becomes very difficult to access the ampulla. Next slide. When you classify the surgical anatomy in this kind, it is either Bile-Rhoth 1 or Bile-Rhoth 2. Bile-Rhoth 1 is a gastroduostomy, retains the normal pathway. So it becomes easy for you to reach the duodenal or the papillary axis. There's not much of difficulty in Bile-Rhoth 1. In Bile-Rhoth 2, the gastrojejunostomy with an afferent limb leading backwards to the papilla. So the main challenge is reversing the direction of the afferent loop. You have to go back, and result little bit for the beginners is disorientation, and that is kinking. And that should be always, we say, short loop. If that is going to be a long loop, GJ has been done, and it becomes very difficult to reach the ampulla then. Next slide. This is a very interesting case because this lady was referred to us after the age of 26. She had undergone exam plus major for surgery when she was born. And after the same pediatric surgeon had done 2 surgeries, then she came to us at the age of 25, where 4 surgeries had undergone. And totally, it was a stuck, frozen abdomen, and we couldn't identify on the MRCP the real pathway. So what you can see there in the image there, and you saw in the fluoroscopy, the guide wire was going across the spine. Whenever the guide wire goes across the spine, it's always a dictum, it is a pancreas. But eventually this turned out to be the common bile duct, which was going across the pancreas. So when the guide wire goes across the pancreas, then I put in the spy scope, and the spy scope also was going across the pancreas. Then it was a very difficult altered anatomy. Then we had to completely clear up. We did the laser, holmium laser, cleared up, and then we put in a stent. We had to do twice for this case because it was very difficult to clear all the stones in one sitting. So this is a very interesting case which we did recently. Next slide, please. In Roux-en-Y gastric bypass, the configuration is a small gastric pouch is connected to the roux limb by bypassing the stomach remnant. So what happens is the biliary drains in the biliopancreatic limb, which is excluded from the conventional, and so you can't reach the scope. So the distance, the total distance from the mouth to the papilla, which will exceed 150 centimeters, which is far exceeding the standard duodenoscope which you normally use. Next slide, please. In Whipple's and Roux-en-Y hepaticojejunostomy, it requires tracking up and reconstruction of the limb past the pancreatic anastomosis. So what happens is the major papilla is completely resected and the biliary entry occurs via direct surgical hepatocentric anastomosis. So what happens is the complete loss of standard anatomical landmarks like the ampulla water happens here. Here again, we have very much difficulties. When there's a long loop, it is a big challenge here to reach the ampulla in the reversing manner. Next slide, please. This is a case, very interesting case, ERCP post-Whipple's. Multiple stones, all hepatic stones are there. We did an ERCP in the reverse using the duodenoscope, but we couldn't reach there. Then we used the enteroscope, we reached there. And you can see I've done the ERCP, I've removed the stones. I put in a stent there. Now I'm doing a hepatic scopy using my enteroscope. You see that there is a stent there. At the bottom, a 6 o'clock image, there was a small erosion from which the patient was massively bleeding. So what happened is we have put in a stent, we have removed all the stones. The patient came back again with a hemoglobin of 5 milligrams. Then we went here, there was a massive bleed from this erosion patch at the hepaticojejunostomy site. So we did APC and then we put a little bit of ferroclium and then we didn't do any clipping of that. And the post, the procedure is this day. On the third day, when I went in there, I just thought I should do an APC again, but there is no bleeding here. And I was able to enter, you saw in that image video, I was able to enter completely into the right hepatic duct, left hepatic duct. The stent was there. He removed the stent, the patient absolutely fine now. It's a very interesting case where the patient had a post ERCP, a bleeding, which is due to basically an erosion at the hepaticojejunostomy site. Next slide, please. And diagnosis nowadays for altered anatomy, definitely the main investigation mode is MRCP, and it's a gold standard. But sometimes CT cholangiography is very useful when MRCP is contraindicated or cannot be done, or the patient cannot be sent into that. And what happens is when you want a precise anatomy and the surgical loops should be identified, definitely CT cholangiography makes a lot of a difference. And of course, the usual lab markers are the liver function test showing an obstructive pattern with an elevated alkaline phosphatase. These are all pathognomic of an obstructive pattern of an obstructive jaundice in an altered anatomy. Next slide, please. The advanced diagnostic tools. Nowadays, I would not say an advanced diagnostic tool because a good endo lab has all these days, and it is an endoscopic ultrasound and which provides a detailed visualization of the common bile duct. But of course, EUS has a limitation. Routine EUS accuracy drops significantly if the stomach or the duodenum cannot be physically transversed due to surgical exclusion, particularly in cases like when you have an ROAGB done, this becomes very difficult to use, that cannot be done, but it also saves the procedure. You'll be seeing up in my coming slides that how he saves the procedure where ERCP cannot be done. Next slide, please. There are two important ERCP methods which has come up now. The one first I'm going to talk about is the device-assisted enteroscopy or ERCP. That's called DAE ERCP. The tools are single balloon or double balloon enteroscopy or a motorized spiral endoscope. In our institute, we use more of a double balloon because we started double balloon way back 20 years before. And the method is over tube is always used, and it's safely pleat the small bowel, and it reduces the length of the bowel so that you can reach. And the success rate, I would say, is around 70% here. And technical success across complex Roux-en-Y also happens in this procedure. So it's called the DAE ERCP. And next slide, please. Double balloon endoscopy assisted. Here you can see I'm using a double balloon. You see the multiple, you saw the fluoroscopy, and I've reached a place which cannot be reached without a double balloon or a single balloon endoscope. I've identified it is a straight viewing. Sometimes without the elevator, it becomes difficult. Once it's done a straight viewing, then the ERCP is the same. And I don't want to show again all the same procedures. Once the cannulation is done, then the routine method of you take the balloon and then do a balloon retrieval, all the stones. And in case sometimes you would like to do one spyglass, but the spyglass doesn't reach the distance when you're doing it with a small bowel endoscope. Next slide, please. The technical hurdles of DEA RCP is the forward viewing optics. As I said, the endoscopes lack side viewing elevator and making it very difficult for cannulation when there's an angle. And accessories, because this endoscope is very long length, you should have the accessories like which are commonly available for this regular side viewing scope, like the sphincterotomes or the extraction baskets. One risk is perforation, because sometimes when there's an angulation of the anastomotic site, the chances of perforation is very high in this. These are the technical hurdles. Next slide, please. The next procedure, which is commonly used for an altered anatomy, is called the EUS-directed transgastric ERCP, or the EDGE. It's an indication specifically for the ROGB. And step one is access of the excluded stomach from the gastric pouch using an EUS. Once using an EUS, you pass the wire into the segmented stomach. Then you deploy a lumen opposing stent into that. And then there are methods in which you do. You do it in a single sitting or in a double sitting. Next slide, please. Here you can see in the left image, then excluded from your, I put in a small red marking there. You come to the excluded part and then you use a regular ERCP. Here you can see we are putting a lumen opposing stent here. Once the lumen opposing stent is there, you slightly dilate the stent immediately if you need to do an ERCP. If not, wait for 3 days. Once the dilation is done, you use a regular side viewing scope, cannulate, and then the ERCP is the same. And it is not as easy as it said, but there are a lot of difficulties when the stent doesn't expand. It doesn't allow the ERCP scope to go, the side viewing scope to go in. So you have to wait for 2-3 days to attain the stent's full expansion. So next slide, please. So the execution and complications in EDGE are the timeline. The standard ERCP is completed through the open lumen opposing metallic stent, either immediately by dilating it or after a short open delay. And usually it is done after a short delay, because the lumen opposing stent, even after dilatation, it doesn't come to the complete dilated mode. So you wait for at least 48 hours, then do it. And the benefit it allows a standard side viewing duodenoscope. You don't need any special instruments to reach the native papilla. The risk, as I said earlier, stent migration can happen during your side viewing scope insertion or during your ERCP itself. And there can be leaks, internal fluid leaks. It can happen from either side, or sometimes a fistula can also happen, and that can be a weight gain can happen. Next slide, please. And this is very rarely done, but it is also a procedure which is done for particularly for ROGB. It is called laparoscopic assisted ERCP, or LAERCP. The method is an operating surgeon when places a temporary trocar. You always put a 10 mm or a 12 mm trocar. And then doing a laparoscope, you get the excluded part of the stomach to the anterior abdominal wall, fix it to the anterior abdominal wall, and you make a rent in the anterior wall of the stomach. And through that, you pass the duodenoscope. Then the entire procedure is the same as you do in a regular ERCP. Only thing, the length is much shorter than you're needed for a regular ERCP. The exceptionally high technical biliary clearance rate is there, because within a short distance, you're able to reach the ampulla, and the maneuverability is very easy. And it's almost 95 to 100% high technical biliary clearance. And the drawback is it doesn't do with an ERCP or a side viewing scope. It converts a purely endoscopic procedure into a laparoscopic procedure. It becomes more invasive. Next slide, please. Here you can see in this laparoscopy, an image here where in the left image you can see laparoscopy is being done on the excluded stomach. You're already hooked up to the anterior abdominal wall. Then you make a rent in the anterior abdominal wall. Then fix it up to the anterior abdominal wall after the rent is made. And through a 12 mm port, you pass in the side viewing scope. And once the side viewing scope is passed, then it becomes easy to do an ERCP. And only thing is the closure should be done properly using a laparoscopic suturing method there. And so you need definitely a surgeon to help you out. And if you are a surgeon, that becomes you need a hybrid third to do in this. Next slide, please. And percutaneous transhepatic cholangiography, as I said, I have not touched on this because I thought there'll be a radiologist doing it. But anyway, it is basically done by the radiologist, where you puncture the intrahepatic bile duct to the intercostal space, and you permit the retrograde guide wire placement, and the balloon dilatation or the stone clearing is done through the proximal route instead of the retrograde route. And indication is best for unstable patient, where the patient is very unstable with severe acute cholangitis and the endoscope could not be done and it fails. And this is the one that really salvages the patient from probably a mortality, definitely. And here our radiologist colleague come to help us, and they do a wonderful job. And you can do all the metallic stents, or you can do all the stents, which all has been done through the endoscopic route, can be done through the percutaneous transhepatic cholangiography. Next slide, please. So intraduct stone clearance techniques which overcomes the difficult biliary stones are endoscopic papillary large balloon dilation, that's called EPLBD. It minimizes the need for massive incisions or an inverted or an altered papilla. So you do basically a balloon dilatation or a balloon ziproplasty is done. And in cholangioscopy, which I showed in the first video, you do a spyglass or any other kind of a cholangioscopy, you directly inspect the duct and the inner walls of the duct, and use an ultraslim duct, and then you can use a laser or an EHL to break the stones. These are done particularly for large stones, which are almost more than 2 centimeters in size. And the lithotripsy, what I call the EHL, which destroys the large stone via an intraductal laser or electronucleic shock waves. Next slide, please. The complications which are usually associated here are perforation, which is elevated risk at the surgical power, anchor loops, and anastomotic suture lines are there. This usually happens when you do these procedures within 6 months of the primary surgery has been done. The chances of perforation is very high. Post-ERCP pancreatitis, which stays as 5 to 10% and is usually manageable with rectal NSAIDs or temporary pancreatic stents can be done. If you have inadvertently put the guide wire or done a cannulation of the pancreas, and enteric leaks, the internal leakage or the tract disruptions follow very early lamps removal, and this also can be treated very easily, nothing to worry about it. Next slide, please. To summarize, the guidelines by the ASGE and the ESG guidelines are the matching patient management to a local center expertise, which is very important, and equipment availability is also to be thought of. And safety is the first priority. Decompressing an obstructed, infected biliary tree takes absolute precedence over complete stone removal. I always tell my assistants that don't worry if you are able to put in a stent, just come back and wait for another week. When everything cholange is settled down, go in and do the second stage. Antibiotic initiate a broad spectrum initially, and intravenous antibiotic immediately if acute cholangitis is present. Next slide, please. Thank you so much. And the core takeaways are tailored care, that is, management must change depending on the patient's original abdominal surgery type. Modern shift, that is, specialized endoscope methods like the EDGE or DAE ERCP are replacing open surgery. A multidisciplinary focus, coordinated care between advanced endoscopists, surgeons, and intervention radiologists optimizes the patient safety. Thank you very much. Thank you, Nara.
Thank you, sir. That was very well presented speech. I mean, so I really learned a lot of things today. I mean, from your talk. I was wondering, in case with the difficult anatomies, you have maneuvered and then reached the ampulla and then cannulated. And then there are also situations where in a regular scenarios where you would like to put multiple stents. So in such cases where already there is difficulty, what is your threshold to put multiple stents at the first place? Do you consider putting multiple stents?
I always put in those cases where it's been a very difficult anatomy and we have struggled to reach the ampulla, I will consider putting a covered metallic stent so that can be removed easily. I don't know, you don't need multiple stents in those cases.
Okay. And what about the anatomical difficulties when there is duodenal diverticulus and all that? So did you?
Yes, you have to be very careful. And as I said, these are the causes where perforations can happen. And so you have to be very careful when there's a duodenal diverticulum. And when there is a duodenal diverticulum, then intradivertical ampulla with the altered anatomy, it's the worst nightmare for anybody. I think that's going to be very difficult to do.
Thank you, sir. Thank you. Are there any other questions here? I'll just see the chat box if there are any questions there. Let me see.
Yeah.
So, yeah, I don't see anyone posting any question here. Any other panelists want to ask any questions to Dr. Govindraj?
Yes. Go ahead, sir.
Thank you very much. I enjoyed that talk immensely. In my days, it was either ERCP or PTC and nothing else. And I agree with you that duodenal diverticulum is the worst nightmare. How do you cope with a Roux-en-Y and a duodenal diverticulum?
That's
for
what I
bariatric
answered.
surgery?
It's very, very difficult. It's the worst thing to happen. And you have to explain to the patient the chances of perforation is going to be very high. In that case, there would be a surgical person, because we do surgeries and we'll have to take him up for surgery. And these are the cases where this laparoscopic assisted ERCP plays a much important role.
Yeah. On a follow-up from that, sir, how easy is it if you have a medical gastroenterologist trying to perform an ERCP to actually get theatre time and a surgeon at the same time? Because we in Britain would find it very difficult.
Yeah, I see. In India, there are few surgeons who still do therapeutic endoscopy and laparoscopy, like me. And the majority of the medical GI people do the ERCP. And there are specialized hepatobiliary surgeons like Bharat. They do exclusive high-end hepatobiliary surgery. And if you're in a good institute, premium institute, you do get these two people to come on the same OT. It's not difficult. And it all depends. That's what I said. My core takeaway is, depending on the patient, availability of the instruments and availability of the personnel who can do these instruments. That's very important when you select the patient.
Yeah, at our center, we very often do these combination procedures where the medical gastroenterologist comes to our help, and as surgeon, we try to give an access to the lumen. Yes.
I think next speaker, I think Dr. Senthil is there. And Senthil Center also, we have a very good combination of high-end laparoscopy or robotic surgery with a good endoscopist. And then, in fact, we did the first, the spyglass discover, myself and Senthil only did it in the entire India. We did the first case that is a combination of endoscopy through a port. We did in the biliary spyglass we did. That's called the biliary discover. And nice to have Senthil here.
So, thank you, sir. Thank you for the opportunity. I would like to thank the IAGES and the entire Great Britain Society for the kind invitation. Let me just share the screen.
So let me introduce Dr. Senthil before he talks his presentation. So Dr. Senthil Nathan is a very is India's one of the leading hepatobiliary surgeon and minimal invasive surgeon, and is currently head of the hepatobiliary surgery department and minimal access surgery and liver transplantation at GEM Hospital. And he has authored more than 100 scientific publications. And being at GEM Hospital, he's also a trainer for many young budding surgeons. And under the guidance of Dr. Pallimelu, GEM Hospital has been one of the most pioneering institutions where high-end hepatobiliary work is happening. So I would ask Dr. Senthil Nathan to take over and give his presentation. Thank you.
Thank you, Dr. Bharat, and the entire team. I'll just share my screen. Yeah, the slides are visible. I hope the slides are visible.
Yes, they are visible.
Yeah.
Please.
So, good afternoon and good evening to all. I'll be speaking for laparoscopic technical tips on bile duct exploration. It will be very difficult for me to speak after Govindraj sir, who is a versatile surgeon and endoscopist par excellence, but I now restrict myself to laparoscopy and GI surgery. I was doing initially, but now I restrict to laparoscopy and GI surgery. I bring greetings from Gem Hospital, Chennai. Just few slides about what's the bile duct exploration. It's very interesting that Kurva is here described first CBD exploration more than 125 years back. Then T-tube drainage was introduced, Merici syndrome was described, and finally in 1991, Jacobs reported first laparoscopic common bile duct exploration. In these changing trends between endoscopy and laparoscopy, I would say that endoscopy is gaining prominence, but nevertheless, we as surgeons do have a role in managing CBD stones. Why I say our role is diminished in the sense, if you look at this Leo's article on management of gallstones along with CBD stones, no role for laparoscopy if in this flow chart, if somebody is having a high or moderate probability of having a CBD stone. So you can see MRCP, then ERC or endoscopic, ERCP followed by lap cholecystectomy. So that means our role is very much limited if it is a straightforward CBD stones. But having said, we are all rescue surgeons with regards to management of bile duct stones. Definitely some scenarios warrant our intervention, warrant our help, including large stones, multiple stones, inaccessible to ampulla like Roux-en-Y or post-gastrectomy, sigmoid shaped CBD, recurrent stones and stones proximal to strictures along with Merici syndrome, intrahepatic cystic duct stones. These are some of the areas or technical failure in spite of repeated attempts or some of the indications for, I would say, ERCP, straight surgery. So my simple answer to what we are for laparoscopy bile duct stones are failed ERCP or inaccessible ampulla. So the present condition or status of CBD exploration, either by open laparoscopic or even robotic, is it's an alternative to ERCP, requires expertise, definitely some gadgets needed, including endoscopic accessories. Sometimes it can be technically demanding. We have plethora of treatment options that are available. Stent removal followed by antegrade stenting. If it is a difficult one, T-tube closures, which we do it very rarely now. I'll also show the primary closure and CBD exploration with bypass. The ones which I marked yellow would be the ones which I'm going to show because these are the areas where we tackle a lot of the CBD stones. Of course, CBD stones, especially in dilated duct, have a lot of advantages, including single hospital admission, shorter hospital stay, quicker recovery, less costly. But it comes with a technical nuances, technical know-how. It requires advanced laparoscopic skills. Coming to the technical tips, we have transcystic approach to CBD, which personally I'm not a proponent. I'll show why in my video. because small stones which can easily be removed by ERCP alone can be removed using transcystic approach. Valves of Easter also will, some of the valves here inside or blockage will make this transcystic approach non usage. Most of the situations we will not be in a position to use this one. So we will be left with choledochotomy, opening the bile duct, milking out the stones, use some endoscopic accessories if necessary, make sure that the stone clearance is done. Stone clearance extraction can be done in very many ways. The simple one would be just a simple two-hand manipulation like milking the CBD, irrigate it, balloon manipulation, and then go for basket maneuvers or choledoscope if in case there is a need. CBD closure is primarily done in most of the situations, but it's always better that you have an antegrade stenting so that the pressure on the anastomosis or on the suture line is less when it comes to post-operative bile leak. The T-tube closure sometimes is used. So I'll start with a simple one, choledochotomy. You can see here, and we also are helped by the presence of ICG. The cystic artery is clipped and divided. As you can see, then as I told you, cystic duct as well as bile duct is amplified by the presence of this ICG. We generally give ICG at least 2 to 3 hours. Now we have taken a decision that we will be giving at least overnight to make sure that it all descends onto the bile duct without the need for you can see this is how beautiful it is seen. This is what I tried in this particular case, the transcystic approach. As you can see, this is the classical description of transcystic approach. So once we try to introduce a little long tube though, but it can accommodate, it could not be done. So I'm converting the transcystic route into a choledochotomy route. We can use cold scissors, energy sources, no problem. So once we do the choledochotomy, now it's all very clear through ICG that it's very clearly seen. There is a stone here at the junction. We remove it. This stone is generally, the large stones cannot come. Even though it's a cystic duct, bile duct junction, still we use a choledochotomy instead of the CBD, transcystic. Then we use laparoscopic ultrasound. That's one way of finding the stone clearance. Then we close the cystic duct opening. This is antegrade stenting. Be very careful with endoscopic accessories. Still we can close primarily, but with the sphincter of Oddi intact, the pressure on the biliary system will be more. So there is a possibility of having the sutures giving one post-operative bile leak. For these reasons, we use endoscopic stenting, endoscopic accessories and antegrade stenting, which is a very useful technique which will reduce the chance of blowout, which will reduce the chance of post-operative bile leak, and this can be done easily. Guide wire, then you have the stent which can be deployed antegrade manner. This is one very simple. Majority of the time we use this technique. Leave the T-tubes and then we see, sometimes we make sure using an endoscope that the tip of the stent is in. That's very important, because post-operatively, if you don't use, we make sure that if it's still within the, then that has to be, already it's a failed ERCP, or for some reasons you are not accessing ampulla, and then going and then removing the stent will be an issue. So make sure that it's cross the cannula and then we can suture it. Suture in an interpreted fashion using 4 OPDs, and then we can able to close all these sutures. Majority of the time, if it is an antegrade stenting, I can say you no need to worry about the bile lake. It doesn't majority of the times. Still, we keep a drain and then close it. But next is in case of large stone, it's jumping. It's taking some time. Videos are loaded, so that's why it's taking time. We'll give adequate time. Yeah. Antegrade stenting, here again, this is one area where some of the stents can get broken, and antegrade stenting will be of much help. As in this case, you can see we are going for difficult bile duct dissection. Use intraoperative laparoscopic ultrasound probe. Use ICG to full extent. This ICG, I can tell you, it's a complete use. It has revolutionized the bile duct surgeries or even routine laparoscopic cholecystectomy. Now you can see there is a stricture down below, and a stent got broken, a guide wire got broken, and these are the areas where we as a rescue surgeons.
Dr. Sendilan, can you check on your audio? There's a lot of disturbance from your audio.
Okay.
Can you check on that, please?
Is it now okay?
Yeah, better, much better. Yes.
Okay.
Yeah, you can go ahead now. Better.
Yes. Now, okay. Now we can be able to, as a rescue surgeon, as I told you, we are all rescue surgeons, and then we can be able to do even difficult scenarios possible. So this is only possible because of laparoscopic or surgical exploration. Now we can see the stent got broken. Endoscopist, you can see this is the area where there is a retail stone as well as a stent got broken. We remove it and then use lavage, and then always make sure that there is no recurrent stones. It can be done by in the form of laparoscopic ultrasound, in the form of choledocoscope, nephroscope, pediatric scope, or sometimes spyglass. As Dr. Govindra sir put in, we were the first to use the second generation spyglass scope for us, wherein it's a surgeon endoscopic interface. So once this is done, we then do the antegrade stenting and close it. So I believe antegrade stenting is the best way of dealing with the choledochotomy. Sometimes the bile duct is so well dilated, so there will not be a need for stenting. I will be showing the next video. Please bear with me for yes. This is very large stone. This is one of my favorite CBD exploration patient. Post cholecystectomy. Patient forgot to remove the stent. There was concretion of stones over the stent, which we could able to do. It was hugely dilated. It's jumping for me also, so I'll just go slowly. So redo surgeries at Porta anywhere in this area is sometimes going to be very difficult. This is, you can see, this is pre-ICG era. You see the dilatation, the extent of the dilatation that is happening. And then this is, as I told you, was one of the largest stone which we have removed. And I am sure even an heavy endoscopist cannot remove these kind of large stones. Such a big stone, as you can see here. Now you see so much. This is one, as I told you, one of the largest stone which I have removed, like a lollipop. So bigger stone. So in these kind of hugely dilated bile ducts, obviously the pressure will, once we remove the stone, the pressure will be completely less, and then we can do primary closure. So primary closure in some select situations, antegrade stenting, the preferred method. Next would be a bypass if it's a stricture down below, or rare if it's a cholangitis, probably we can place a T-tube. If the stone clearance is incomplete, we can have a T-tube. This is the way, these are the technical tips by which we can handle the large or the choledochotomy wound. So now the closure becomes easy, and then we can go for a post-operative, drainage. Drain tube, generally we keep it for all CBD explorations. My last half would be on indication for bilioenteric drainage. In fact, we also published a paper of our increasing need for bilioenteric drainage, because majority of the stones are managed better with ERCP. We will be left with dealing with complicated stones, wherein especially these are the indications: marked dilatation of bile duct more than 2 centimeters, multiple or primary stones, stricture, this is main indication, stricture, a benign stricture, proximal or a distal bile duct or a sphincter, inability to remove stones, multiple stones, recurrent stones, stricture down below, that's the third operation. These are the indication for bilioenteric drainage. The options are transduodenal sphincteroplasty, which we rarely do. Either it's a choledochoduodenostomy or choledochojejunostomy. And here, for these benign indications which are low down, most of the time it's the choledochoduodenostomy. A very good procedure, and I would say that it's one of my favorite procedure. Compared to, at any given day, I'm a fan of hepaticojejunostomy. But here, for bile duct stones with a stricture down below, whenever there is a need for a bilioenteric drainage, like in this case, we mobilize the duodenum down, make it freely available for the anastomosis, and then do the duodenal anastomosis, because it's right there. And more importantly, we still have the access endoscopically when there is a problem in the future. So this is the last video I'm going to play. This is a video of a recurrent stone with a stricture down below, a benign one, long-standing stricture, so that you can see this can be tackled. So now again, a large stone, dilated bile duct. This is again even without the ICG, we can able to aspirate and then identify, make a clean cut onto the bile duct, which is between the 6 and 9 o'clock position, so that 9 o'clock and 3 o'clock position, so that you don't injure the pericholedochal plexus, which are the main source of blood supply. So we in the middle, not at the right border, not at the left border, in the middle of the bile duct, we just open. And other technical thing is we don't open high up, because these are the anastomosis which are done for benign indications, and we should not go all the way onto the porta. So it has to be in the supraduodenal portion of the CBD. So once we do this, we extend all the way up to the point where the anastomosis can be easily performed. So here, like in any other choledochotomy, we open the bile duct as low as possible, so that we leave the virgin bile duct or hepatic duct untouched. So now we have the stone clearance, large stones, as you can see. There are very many ways of tackling these stones: nibbling the stone, milking the stone out. These, you can see, these are some of the stones which got firmly stuck onto the mucosa of the bile duct. Still its stone got broken. So it's a combination of blunt and sharp dissection, and we need to have patience. We need to give adequate force, not too strong, not too small. So then you can see this is the large stone. I'll just go through. This is, you can see, it's going up, but we could able to remove it by the key is to open it low and then do the stone clearance. Give nice lavage. Once that is done, we do the choledochotomy. It's one of the beautiful procedure described, an elegant procedure that's described, wherein we open it at the lateral border of the duodenum. It's a diamond shaped anastomosis. Just see the anastomosis here. It's at the inferior end of the bile duct opening, choledochotomy, to the middle of the duodenotomy. That ensures that we have the diamond shaped anastomosis. So this is the first step is the key. I repeat, the edge, the end, the inferior most portion of the choledochotomy wound to the middle of the jejunotomy wound. Once you do the first approximation, then we are in for a nice anastomosis. That is a nice diamond shaped anastomosis which can have a patency rate of close to 95%. Even this is better than hepaticojejunostomy, because this will give a nice opening, the stoma is big. And you see here, there is no tension on the duodenum. And the SUM syndrome, ascending cholangitis, which we generally see or read it in the textbooks or foreign view, we can very well use this procedure. For any other benign biliary stricture, we could go for other indications like for post-cholecystectomy injury, bile duct injuries. We can go for an hepaticojejunostomy, which is higher, but this is a stricture which is low down. The biliary anastomosis can be done using this duodenum as the bilioenteric drainage route. So now you can see, as we come, we try to close right and the left side together, so it just hugs the bile duct. The duodenum hugs the bile duct. It's just pulled on to the bile duct without any tension. So this is, you have to do it on both sides, so that we narrow the opening as we go up. So now this is the completion of the procedure. Again, the edge of the superior corner will be approximated to the lower lip middle. That is how we form a diamond shaped anastomosis. So these are my technical tips with regards to the management of bile duct stones by laparoscopy, and definitely it's a very safe procedure. chance of pancreatitis is almost negligible, so that I don't go into the nuances. But what we are there now as far as management of bile duct stone is one stage. Centers like GEM, centers like Govindra's center can do this procedure, can take it in a big way, because there are expertise available. It's basically a logistic issue. In one go, we can go for a single stage endoscopic management, wherein when the expertise are available, just lap cholecystectomy following ERCP would be the best. We don't in uncomplicated bile duct stones. So my take is a single stage laparoscopic procedure, and if it fails, always there is a rescue procedure, which is laparoscopic CBD exploration, which is a one-stop solution. Tailor-made approaches to various scenarios do exist, and even in this era of more and more minimal invasive scenarios, definitely we the surgeons will be the rescuers, and ultimately CBD exploration is a bailout procedure. Once again, I thank the opportunity and sorry for the technical glitch. I'll be happy to answer any questions. Thank you, Bharat. Thank you, the council, for the kind invitation.
Bharat, you're in mute mode.
Yeah, thank you, Sandilnathan. It's a wonderful presentation and very well illustrated videos. I don't have many questions to ask, but what is your take on intraoperative cholangioscope to see the stones on the other side, like, on the biliary tree? Now you have told us that, you see very often using a endo ultrasound to laparoscopic ultrasound to see the distal end. What about the upper side? Do you routinely perform a cholangioscope to see the biliary tree, especially extending into first degree, second degree biliary radicals? Do you do that?
So basically, we have the preoperative imaging, either in the form of MRCP or CT scan, but preferably MRCP, that will give a clue how many stones we are managing. If there are multiple stones, say for example, the one stone which I have like a lollipop, it's very clear that you remove the stone, give a wash, and the break contour of the stones is not damaged. We are sure that it's removed. Only lavage is enough. No need to check. But that's not the case in majority of the time. We are left with sludge. We are left with stones which are either too proximal or too distal. So it's better that we have the stone clearance mapping done. And off late, the simplest one would be laparoscopic ultrasound. But laparoscopic ultrasound is not available in majority of the scenarios. I do agree. Even I believe in UK it's the same. In such scenarios, we have to use other gadgets. First is a nephroscope. It's a rigid one. Why I say nephroscope is, whether it is spyglass or choledocoscope or pediatric scopes, these are slender, delicate instruments. They will not be a sturdy one, and definitely once you use a choledocoscope or even a pediatric scope, next to few days you will be going to have a complaint of leaking channels. So it's all delicate channels. So my preference is, first is laparoscopic ultrasound, next is a rigid nephroscope which can be used coming from the epigastric port, which you can visualize both proximal and distal. Third only is the direct visualization using scopes. We also have the choice of intraoperative cholangiogram, a conventional cholangiogram, but again that is tedious. But if we have one, we can do that one. These are the ways by which we make sure that stone clearance is complete. But without this, any of this, in multiple stones, in proximal stones, I think we should not be in a position to close it primarily without checking that stone clearance is done or not.
Thank you. So there are
what do you do, Dr. Bharat?
So we use a nephroscope, Dr. Sandil, to check to the other side also. because a lot of times when we try to mince the stone out, there can be a chance that there are a few small fragments of the stone can slip out. And also we traditionally try to give a wash into the CBD by pushing, water, saline with pressure. So that may also dislodge some of the stones into the upper tract. So I prefer to do a cholangioscope for the completion's sake, or else do a cholangiogram at least before closure of the CBD.
Yes.
So there are a couple of questions from participants, audience. So one of the question is, do you close the CBD transversely or longitudinally after the choledochotomy?
It's longitudinal. Longitudinal closure because the length will be a little long. Closing it and the opening is as we open, we close it. It's as simple as it is. Transverse, we have tried in few cases long back, but we don't follow. It's a longitudinal opening and closure. And the second closure is also a longitudinal, so that you don't create any tension over the anastomotic site. It's unlike the bowel. Bowel, we open it and then transverse closure is always preferable to avoid stricture. But here, in case the alignment doesn't allow us to close transversely, even if you open it longitudinally. So preference is open it and then close it in the same axis as we do open.
Yeah. So there's one more question from the audience. So they're asking, after what date? After how many days after surgery do you remove the antegrade stents?
Anywhere between 1 month to 1.5 months. That means 15 days to 6 weeks we can remove the stent. But generally we leave it for a month or so. It's a balance, not too long, not too short. It's about 4 weeks.
So one action question for what questions were asked. So did you encounter any strictures in long-term follow-up patients when you close these bile duct openings? Because the traditional teaching says that when you close that.
Dr. Bharat, are you here? I'm also seeing the Kanavel sir, President.
I think Bharat lost connection, Sendil. He was
Yeah,
asking about the closure. You were telling about the vertical closure. He was asking whether he is saying that the horizontal has been the teaching. Why do you say vertical?
Okay. One majority of the time we will be having dilated CBD. So closure doesn't result in stricture all the time. So after era of ERCP, we are dealing mostly with dilated stones. In fact, I would say undilated ducts, it's very difficult to manage nowadays, because a 4 millimeter with small stones, inaccessible ampulla, they are very dangerous than large dilated bile ducts. But nevertheless, we continue. There is an antegrade stenting that again will allow us to have the bile flow, and also it heals. The second thing is the opening is more than the transverse opening and then removing that stone. Majority of the time is not possible. We sometimes here the extension, up and down extension is very much possible. We can tailor according to the diameter of the stone. But here in transverse opening, it's limited by the diameter. We cannot go more than half of the circumference. Then we will be doing complete transection, or we'll be going posteriorly, jeopardizing the vasculature. You all know pericholedochal plexus that runs at 9 and 3 o'clock. So those will be damaged. So always it's safe to open it longitudinally. And then porta, even we can extend all the way. Classically, hepatite jejunostomy is a longitudinal incision wherein we don't have boundaries. We can extend all the way up to the segment 3 ducts. So longitudinal opening is preferable.
Thank you, Sendil. Kanagavel, is there any more questions? We will ask Sendil. Kanagavel?
Yes, sir.
Yeah. Are there
Uh,
any
I
questions in the
think
chat box?
Sir has raised his hand. Does he have any questions? No? All right. So I have some information about the upcoming program to be informed. Next program will be on foregut emergencies. We have a talk on esophagus and gastric perforations. I think there is some feedback. Sorry about it. If someone is joined in two devices, kindly mute yourself. Right. So this information of regarding the dates and speakers will be shared to you shortly. And you're also welcome to write to us, either to us at IAGES, to the president himself, or to Dr. Selvashekhar, president of the ALRSGBI. Should you wish to include any specific topic, we are eagerly looking forward to interact with you. Things apart, IAGS has very important academic activities upcoming. The next important thing is the mid-IAGS at Bangalore, the last week of this month. And then IAGS is moving to Harvard this time. Whole of August, last third week, IAGS is with Harvard. We are partnering with them with the MINT program, where the Mass General Brigham and the IAGS is collaborating for 3-day long program. Those are interested are welcome to join. And then coming month, IAGS is partnering with the ISUCRS, the Global Consortium of Colorectal Societies. Those who are interested can reach one of us for any registration assistance. And then, of course, the last week of November, all of us are coming to the United Kingdom. The Trafford and the lot of combined work has been planned. Stay tuned for the information about the combined information about what people are planning to do. And of course, the next IAGES annual meeting is planned for February at Delhi. So these are about the upcoming academic activities. So apart from that, we do our own basic and advanced fellowship programs on various grounds. I wish all of you could visit IAGES.in website for further information, and you can communicate through the IAGES website itself. So thank you very much. And anyone would like to add any comments?
There is one more lecture.
Of course.
Kanagavel, there is one more lecture.
Of course. So thank you. And I think the UK team can take up the next introduction part of it. Thank you. Thank you, Sendil sir.
Thank you, Sendil. Thank you.
Thank you, sir. Thank you, Govindraj sir. Thank you so much for the opportunity.
Thank you.
Well, hello from the UK. Thank you to all for joining. Graham White here. I'm not, as it says on the indicator on the computer screen, a second Chelya Selvaseka. I would like to introduce Mr. Altaf Awan, who is a consultant surgeon at Derby Royal Hospital. He's a fellow member of the ALRSGBI Council, or ALRSGBI Council, should I say. I've known him for many years. He's a specialist in robotic and laparoscopic bariatric and benign hepatobiliary surgery. And today he's going to speak on practical tips for cholangiography.
Graham, thank you so much for your kind introduction. There have been brilliant talks this afternoon, evening. There are quite good questions actually on the Q&A. We'll be more than happy to address them. If we have time, depends upon what time is. You can decide that. But some lovely questions are there, which are well worth addressing. So I'm Altaf Awan. I'm going to just talk about intraoperative cholangiogram, some practical tips there. These are some of my disclosures, but none of these are relevant to my talk today. Now, the structure of my talk would include why and when intraoperative cholangiogram, and this debate, which has been there forever, selective versus routine. There are some procedure steps I'm going to go through, which will be good for trainees to watch. There'll be some practical tips. And then the important bit of intraoperative cholangiogram interpretation, that's the most important thing. You inject a dye, you can't read it, it's not worth it. There are limitations of IOC, and in those circumstances, where there are limitations or you can't perform it, there are other options available, and I'll briefly touch on those before my conclusions. So why and when to perform intraoperative cholangiogram? I think the most important thing in biliary surgery is safety. And we all know, that the bile duct injury is associated with significant long-term impact on quality of life and reduction in life expectancy. So we have variety of modalities available, and it's important to recognize that they're all complementary. Here you can see a cholangiogram. In the middle, you can see an laparoscopic or robotic ultrasound, and there is role of fluorescence imaging as well. If you look at the most recent SAGES guidelines actually published this year, it's interesting that they are going towards some conditional recommendation for routine cholangiography. Conditional recommendation basically refers to, that the desirable advantages of an intervention are sort of superior to undesirable effects. So hence, there's a bit of a move towards routine IOC recommendation from American publication recently, and this is more relevant in the pediatric population as well. The other point, which is from this publication guideline, is that it will be intraoperative cholangiogram or laparoscopic ultrasound rather than ICG. We'll come to it in a minute, what it means basically. Second is that debate all the time going on, selective versus routine. To be fair, it depends on which healthcare system you work in. If you're working in a publicly funded healthcare system where there's a large volume being done in day case, you don't have enough time to perform a routine cholangiography, and you have to be sensible regards to your case selection so that your day can proceed without any obstruction. Doing a cholangiography in a day case unit is next to impossible in the UK healthcare because your volume is such that you can't interrupt, it will impact hugely on the resources. So despite this review article, well worth reading it, which supports again, in the American healthcare system, routine use of intraoperative cholangiogram and suggestion for improved training, it is not practical in the healthcare like UK NHS. So most of the work which I'm going to present here is what I do in my day-to-day practice. It's what the real life scenario I'm saying. So I'm one of more selective intraoperative cholangiogram person. I like doing cholangiogram, but physically it's not possible to do it on each and every case. So I select my cases like people who suffer from cholangitis, pancreatitis, or jaundice. Simple sort of common sense approach is certainly a stone has dropped into the bile duct. Whether it has passed or not, who knows, but it's entirely sensible to undertake a cholangiogram in those particular cases. Certainly, if you do it routinely, then it impacts your operative time and resource utilization. When it comes to routine intraoperative cholangiogram, in general, previous speakers have mentioned with regard to altered GI anatomy, where you have a biliary bypass, where you have previous surgery where proximal GI tract have been bypassed. So the access to the GI anatomy for ERCP is not straightforward. Hence, in these group of patients undergoing cholecystectomy, you should do routine cholangiography so that you have, even if it's negative, it's well worth doing it during cholecystectomy. Even if liver function tests are normal, I do them routinely. And same recommendation of such children, I tend to do them. I do sometime sort of 14 to 18-year-old group where they have hereditary spherocytosis or sickle cell anemia. I tend to do an intraoperative cholangiogram because sometimes you are able to manage new findings during surgery as well. The most important sort of concept of intraoperative cholangiogram is that it gives you real-time delineation of biliary anatomy or whether or not any stones are present inside the duct. Mind you, if you have a MR scan done day before, stone will drop in the middle of the night. So the patient coming to you next day may still have a bile duct stone, but don't rely on the scan done even that morning or day before, because gallbladder is a dynamic organ. It doesn't stay still, it contracts. So stone can migrate. So it's important to know, the concept behind undertaking cholangiography is to do with how the gallbladder works on a day-to-day basis. A little bit about liver function test, certainly diagnostic accuracy goes up, the higher the values are, no brainer. But normal LFTs are usually highly accurate negative predictor of bile duct stones. Still, you can have 3 to 7% risk of finding a tiny stone, but usually those will pass spontaneously. Bilirubin, alkaline phosphatase, and gamma GT remain the most sensitive markers, indirect sort of giving you evidence something there is there in the bile duct. Now, imaging of the biliary tree outside OTC, like ultrasound, MRCP, EUS, in certain cases CT scan or intraoperative ultrasound, they're all complementary. It's important to know that sometimes you may have to use them in combination to get the best possible benefit to your patient in particular scenarios as well. Now, steps of intraoperative cholangiogram. Normally, what my practice is the standard laparoscopic cholecystectomy setup, and it's the site between your epigastric port and the first right upper quadrant port, which is in the mid-clavicular line. That's where I pass the needle, which is a size 14 abocath, and through that I pass my cholangiocatheter into the cystic duct. But it's important to obtain a critical view of safety, and callus triangle is delineated. You clip the proximal end, the gallbladder end of the cystic duct, followed by a small ductotomy and introduction of the cholangiocatheter, which has been already primed with saline. The importance is that once you prime with saline, there won't be any air bubble or vacuum inside the tube before you attach the contrast to it, which normally I do a dilute contrast, 50-50, because in neat contrast is quite dense and you can easily miss small stones. Now, this is an ideal case, where you can see a cystic duct, you can see the bile duct briefly displayed, you have displayed all the callus anatomy. I think it may not be always possible depending upon how the artery is passing towards the gallbladder, but general teaching is that don't clip the artery before you have performed the cholangiogram. But with ICG available nowadays, you can light up that cystic artery and you can confidently clip it before you do the IUC, or sometimes the artery is passing in an unusual course in front of the cystic duct. You have no choice once you have confirmed it is the cystic artery, and then you can clip it before performing. But in general, the rule is do not clip it until after obtaining the cholangiogram. Here I've shown a standard clipping towards the gallbladder, tiny clip on the cholangiocatheter before your intraoperative cholangiogram. The red loop I've shown in the picture to your left on the image is basically I'm trying to show that you will come across situations where you can't apply the clip across the cystic duct or the cystic duct is very short. So what you do is use an ovical tie towards the gallbladder end so you don't spill any stones, don't have any leakage coming there, and it will provide you enough space with a second loop of vical on the catheter instead of a clip to perform the cholangiogram. So either clips will be possible with a standard kind of a cystic duct, or sometimes, that area can be inflamed, thickened, clip may not stand there. Use one of these sort of a temporary vical suture ties. You can do a slip knot, easily on both sides over the catheter towards the gallbladder end before you perform the cholangiogram. Now, I'm going to show an OTC, real-time intraoperative cholangiogram, and I'll stop it at a few seconds just to show you something. So I stop here, So you're looking at the distal filling of the bile duct with a filling defect. Now, you should never accept this cholangiogram, never, because if you accept this cholangiogram that it is fine, there's a possibility you have clipped the proximal system. So what you need to see is the proximal filling of the biliary tree. So never accept antegrade filling of the biliary tree only. You need to make sure it goes proximally, it goes towards the right-left hepatic duct. Whether or not you get any duodenal filling will depend upon the type of stones, obstruction, or there's some passage across it. So it's just a bit of a intraoperative key step, not to be missed. Don't accept antegrade cholangiogram only. It has to show the proximal filling for it to be a complete cholangiogram. Now, interpretation, I will do and decision making. Now, it's a very good procedure for trainees to get trained in. They enjoy it. It's the step up from their normal gallbladder, average gallbladder, to an additional intervention surgical. They learn the clipping, or if they have to put a tie around the cystic duct, they learn those steps and they really enjoy it, And this is an ideal sort of a cholangiogram, which is showing, you have got right-left system being failed. You have got common hepatic duct displayed. What trainees need to understand is, they should see how the cystic duct follows front, behind the bile duct towards the ampulla, and where the filling defect is, you see the convexity. So I've marked some of these areas: short cystic duct, a filling defect at the bottom of the bile duct, and cystic duct appears to be taking a slightly long course, but appears prominent, and that could be a good way to access the bile duct via the cystic duct route. Now, this is another cholangiogram, very short cystic duct, but it's amazing. You can see the bile duct fully loaded, with stones. These are proximal stones, distal stones, and they are large stones. Now, trying to go through the cystic duct is amazing. I'm sure there was some form of, usually secondary bile stones in European countries are rare, but stones lying there for years can grow over a period of time. So the cystic duct may not have enough room, or with transcystic route, beware that you may not be able to flip the scope into the proximal system. In UK healthcare, any good center doing bile duct exploration has got full access to flexible scopes. You should not complete your bile duct exploration unless you have done a completion cholecystoscopy. Cholangiogram will give false negative bubbles inside the thing because you have introduced, fluid and bubbles inside it. So the direct inspection with flexible cholecystoscope is the key. Now, there's another situation where you have got these stones. Pre-op imaging has shown you something, but intraoperative is the key. Here's the stone, which is towards the left hepatic duct and coming towards the confluence. So intraoperative cholangiogram will help you decide the location and the need for intraoperative adjunct. So we have got a full set of electrohydraulic lithotripsy, laser available, not to extend the cholecystectomy beyond certain few millimeters. Important not to make a big vertical cholecystectomy, for these cases, even if the stones are big. You should have these additional adjuncts to smash the stone into little pieces before you take them out. This is another, these are two another images. I'll give you the relevance here. So sometimes you perform an intraoperative cholangiogram. So here the trainee should read how the cystic duct is coming towards the bile duct. Now, mind you, the normal sort of attachment of the cystic duct to the right lateral end of the bile duct will be just under 50% of the cases, not always. So sometimes it's the posterior, because it runs a long course as well. And that has got important implication if someone is thinking of transcystic approach, especially if the cystic duct if bile duct is not dilated. You can't open the bile duct if it's non-dilated. So you've got to have all those concepts. So understanding how the cystic duct is running along the bile duct, whether there's a true defect or it's just one of those hold up, it's important to recognize intraoperatively as well. And things like I use hyoscine as and when required, but I rarely use glucagon. You need to have a very expert anesthetist who can manage that sort of a sugar levels. If you give glucagon, it can cause profound hypoglycemia. Flush technique I tend not to use normally, because stones can migrate proximally in a non-dilated duct and you're stuck, you don't know what to do. But certainly flush, once you open the bile duct for a transcholedochal, has got its own advantages as well. So it's just these images showing some of those things you need to do. Interpretation should be correct intraoperatively. Now, coming to a few last slides, so special consideration and minimally invasive surgical adjuncts. So here I'll show you a brief video. Now you have cases like pregnant patient. This is a patient we did recently. She's about, this uterus is just above the umbilicus, so it's just entering the third trimester. As you know, the SAGES guidelines, and if you do regular bile duct, you know that it's safe to perform lap cholecystectomy if they present to you, and if they're bile duct stones, you can address them as well. But requires the right setup. You should have the technical expertise, and in those situations, you can't do intraoperative cholangiogram. So options are either intraoperative ultrasound, requires experience, right type of assessment of the biliary tree, can be tricky in the distal bile duct or proximal bile duct. So it can be false negative, stone may be there. So what you'll see is, if you have access to 3mm cholecystoscope, you can get an excellent view of the biliary tree after you have done the adequate mobilization. This is showing a bit of a uterus down south towards the pelvis, the gravid uterus down there. And here is introduction of a 3mm cholecystoscope into the bile duct, to check the distal end. So here you have an excellent view all the way down to the ampulla you can get. So keep in mind that in those circumstances where you have to do a gallbladder surgery, especially in pregnant patient, even after LFTs have become normal or returning to normal, don't overlook the examination of the cystic duct, bile duct, sorry. So I have got access to 3mm cholecystoscope, well worth having that available. Now, a few more points about, we talk a lot about these days about intraoperative ultrasound. So in my center about 10 years ago, I had a very difficult revisional case, I'll show you a quick clip. And the anatomy was so distorted, previous cholecystectomy with a big stone, and I thought I'm looking at the bile duct, and guess what, it was portal vein. It was recognized straight away because it didn't look sort of a normal, the whole thing area looked twisted. And obviously, those kind of things, you do risk assessment, you ask for additional tool, and we are very lucky that we have got adjunct like, intraoperative ultrasound. Here you can see where the stone is in the bile duct, where is your hepatic artery, and where's the portal vein, So it's well worth keeping in mind that if you are planning something, you need to have all the adjuncts in for a biliary tree. And just a quick one on the fluorescence guided surgery. The limitation of ICG is it can't identify the stones, but it's a brilliant thing in select cases. If it's a badly inflamed biliary tree, thickened peritoneum in front of the bile duct, you have to dissect off to see the bile duct. It may not be obvious, but here you'll see a little clip where it shows, how it can improve your intraoperative safety, and it acts as an adjunct to your intraoperative cholangiogram. Now, if there's a thickened tissue in front of the bile duct, no matter how long the ICG have been given, it won't show up. You have to release that fat in front of the bile duct, and once you have done it adequately and the dye has been given 20 minutes, half an hour before surgery, it will light up beautifully, because one of the things which bile ducts which has got stent in, it will look like an artery. So once you have checked, the biliary tree with ICG, that it won't clear, for a certain number of hours, whereas an arterial thing will clear very rapidly, So here I know a whitish looking tissue is bile duct, rather than an artery. Now, limitations of IUC, like, sometimes you can't cannulate cystic duct, air bubbles can give you false positive or false negative kind of situation. If there's a cystic duct stone, you won't be able to cannulate. So usually when you open the cystic duct, you should get some bile coming backwards. If it's not coming, think likely there's obstruction in the cystic duct, which could be a stone. Okay, severe cholecystitis is another limitation. IUC, you can accidentally cut towards the bile duct without recognizing, so just be aware of that. And certainly limitation for children and female in childbearing age for radiation exposure. Now, the final bit on this slide is about the robotic approach. There's a lot of literature coming out in JAMA talking about bile duct injury, whether it's the learning curve effect or whether it's some sort of a, poor training, in robotic surgery, but there's a lot of multi-port and single-port surgery going on. Key thing is you should have good training. There's a limitation for IUC. You need to know how to undock, do the OTC properly. Don't try to sort of do less than perfect. Keep to the perfection in biliary surgery. In conclusion, certainly IUC is a valuable tool. It has got high diagnostic accuracy, gives you the stone diagnosis and anatomy. And approach varies depending upon, what situation you are in. You can have additional adjunct available, to help improve your diagnostic accuracy to prevent bile duct injury. Surgeon training and expertise is the key, and it's a procedure which trainees love. It's important, to get them confident in this procedure. And certainly, this is a laparoscopic task which trainees love to learn as well. Thank you so much for your listening. Do look after your health. Important. Family is important. You've been good audience, and I'm happy to take any questions.
Hi, sir. This is Dr. Bharat from India. So can I ask you a question regarding this IOC?
Please do. Yeah, please do.
So one important thing everyone faces while doing IOC is interpreting the findings. One can do the IOC very easily, if not, but then interpretation of the findings is the most difficult thing one would face while, during the procedure.
Is that what?
So can you give us a little insights into
Sekhar,
like?
you need to be on the mute. If you need to mute, so tell Sekhar to
Okay.
mute. I think Sekhar is on the speaker. Prof. Sekhar, yeah. Do you want to ask him to mute? Is it? He's on the phone.
Sekhar, are you listening? Can you mute your mic?
But you speak it at the NG tube, yeah? Okay, but he has not been sick. Okay.
Sai,
Sekhar,
can you mute him, please?
Yeah, he's muted. He's
okay,
muted.
muted.
Lovely.
Yeah.
Now, so
Thank you.
it's a brilliant question, Bharati. Now, I think I know you're very keen. I think CBD exploration. The way UK system worked and the way I learned to perfection. You need to be perfect in this thing. Is my training. I worked with pancreatic biliary surgeons who are both good at cancer and benign surgery, and my spend time in pancreatic biliary was close to 2 years. And one of the thing was, I was allowed to do OTCs. I still encourage my trainees to do the same, and you need to get them trained. Stand back from them, let them do it, and ask them, what did you see? You'll be surprised how even consultants can misinterpret it, do the misinterpretation. Then we have regular radiology X-ray meeting, which does occur, and we encourage trainee to attend those meetings. Even if they attend once a month or once every 2 months, it's well worth it. You review those images. Real time is the key. I think you need to have a hawk eye. As you inject, you see, that's the best. Static image has no role. Okay, so that's what you need to sort of a guide. I think key thing will be patient with your trainee, let them learn it, and they'll become a very good surgeon. But it requires over a period of time this training. So what I referred to was, so as I said, UK healthcare limits you. You can't do routine OTC. Okay, so I do when I know there's a high risk of bile duct stone, but I select sometime patients for trainees only, where they can do dissection and intraoperative cholangiogram and read the report to me what they see, and that's how you're going to improve it. It's just all down to training and practice. Yeah.
Thank you.
It's all right.
So, Altaf, thank you very much for that talk. I'll just ask you a quick question because we are running short of time.
Yes.
Why are you actually doing cholangiogram? Is it for stone or anatomy? Because in the days of open surgery, we'd gone down to selective cholangiography as our policy, as you've now adopted. But when we first started laparoscopic surgery in the early 90s, I was forced to do cholangiogram by my boss every case.
Yes.
Now, why is the change? Were we fearful in the old days or were we not?
Graham, you're spot on there. So there's a very good track. I think if you look at publications, when lap surgery started, the bile duct injury went up. So you're absolutely spot on. Your consultant will be breathing down your neck, get the cholangiogram done. I want to see it, But with time, with the training, critical view of safety, callus triangle, where consultant got fully trained, the way we're seeing in robotic surgery now, and consultant got trained in lap surgery. They transferred the skills to the registrar during their 6 years training, which automatically translated to better performance in theaters. So certainly for the need for anatomy has become less and less. Plus there are bailout options obviously nowadays when you come across nasty ones. But dominantly, if you ask me, almost always is to locate where the stone is, the need for adjuncts like do I need lithotripsy for this case? I need to sort of prepare the staff, this is going to take longer than anticipated and may have to cancel one of the cases. So that kind of thing it gives me, during the day, keep everyone happy.
Okay, thank you, Altaf. So from the UK side, that concludes, I think, our webinar management of common bile duct stones. I'd like to thank personally Dr. Bharat on the Indian side. I'd like to thank Dana for doing the hard work in organizing. I'd like to thank Kanagavel all the time, as usual. Thank you all. I don't know, Bharat, if you want to close from the Indian side.
Thank you all. It's been a wonderful meeting, and really, we all learned a lot of good things from all of you. And from our side, I think we all had a good time together now. I think we can conclude this meeting if Dr. Kanagavel is around. If you can say a few last words before we conclude. Yeah.
So thank you very much. I'll expect quick word from both the presidents and then we'll call a close, please. Dr. Selva first.
Thank you. I think it was a fantastic webinar. Thanks again, Altaf, and I think Hula has left, but it has been a great webinar to learn, see what every similar pathology is being dealt with in a slightly different way on both sides. And thanks again, Dana and the rest of the team for organizing it from the UK side. Thank you. Thanks very much.
Dr. Govinda, sir, please.
Thank you, Selva, and the ALRSGBI team, entire team. And lastly, Dr. Altaf, it is a wonderful lecture because nowadays not even 5% of them do IOC. So it's a diminishing specialty, what I would say. So, but anyway, you've explained it very well. And thank you, Bharat, and thank you, Kanagavel, and Dr. Senthil for this. And from the ALRSGBI, thank you, Dana, Dr. Altaf, and the entire team. And thank you, Sai, for this wonderful thing you have from the Sai Numerotech. Thank you so much.
Thank you very much. Dana, would you like to tell something or share some information from your side?
No, just many thanks from my side as well, because it was very obvious how much effort went to preparation of all the talks, including great videos and very practical tips, which I believe everyone will benefit from now onwards, no matter if it's upper GI surgeon, HPB1 or a general one. So thank you very much and have a good rest of the evening.
Oh, yes. And then I would like to document that people have taken so much of effort to give talk. I would say each one of gem of a talk where they put in so much of experience and original work coming up. These are all, like I would say, will form a treatise for the youngsters who are into HPV or general surgeons who have special interest in HPV. Maybe we need to find a way. I'll also find a way if I can add this to IAGES website, invited like special lectures or something like that. So I'm sure the quality of the talks have been going up by the meeting. That's all I can tell. In fact, there were a couple of comments in the group telling, are we exceeding time? I just had to keep quiet considering the quality of the talks. But of course, we need to implement time boundaries. That I will find a way to do that. But then the quality of the talks was exceptional. That's all I can say. And then all good things have to come to an end. And I wish all of you good night and good evening. Thank you very much for joining. We look forward for the next meeting and we shortly expect this information from our side. Good night, everyone.
Thank you.
Thank you, everyone.
Bye-bye.
Bye. Have a good time.
Thank you.